All right. Hey, everybody. Sorry, I was going to start singing a little CCR for you and keep right on going with the sing-along, and we could just do that for an hour. But no, let's talk about some geriatric health, and we're going to be focusing on brain health today. So thanks very much for coming out. This is Peer Review Live Brain Health Morning Report, adapting primary care practice and workflows to meet the needs of an aging population. So my name's Chuck Vega. I work right down the street from here. Welcome to the land of the mouse, everybody. So yes, how many of you are from SoCal? Okay, so we're getting about half. All right, well, welcome if you haven't been from here. If you're not from here, the SoCal people can try, if you're going to the parks, they'll tell you what you need to know so you can have the best experience possible. In my real life, though, I'm a family physician. I work at the Federally Qualified Health Center down the street here, and I'm very proud to do that for almost 30 years now. I'm also assistant dean and run our program in medical education for the Latino community at University of California, Irvine. Scott, do you want to introduce yourself a bit?
Sure. Scott Kaiser. Welcome, everyone. I'm a family physician, geriatrician. My practice has been exclusively focused on cognitive health care, dementia care for over a decade, and glad to be here. My practice is in Santa Monica, right down the street the other way.
There we go. And we have a very special guest who is appearing to us via technology. Malaz, can you, oh, there he goes. Do you want to introduce yourself for a second?
Yeah, I'm Lex Scott, a geriatrician and health services researcher at Indiana University, and I specialize in creating and organizing healthcare system capable of transforming brain health for all for better now.
Great. Okay, well, thanks. It's always that first moment when you have somebody on who's virtually here where it's kind of like, oh boy, here it comes. And that was perfect. Great job, Malaz. Thanks very much. And I just want to say hi to our online audience. Thanks very much for participating. We're going to give you a good show today. So we want to thank, first of all, Peer Review for providing the session. Lily provided an educational grant for the symposium, but had no say in the content of what we're presenting today. If you haven't done so already, please fill out the pre-event survey. And the more you ask questions, the more you complete the polling, the better the chances, I understand, are for you to win the second prize, which is at the end. So there's another gift card coming down the pike at the end of our session. So try to make this interactive. We'll try to do so as well. That way, I think you get more of your questions answered, and it helps whatever we're trying to talk about today to stick a lot better, and so you can use it in your practice. We're going to try to be highly pragmatic today and give you things you can go back to your practice and use tomorrow if you wanted to. So with that, this is your chance. So I think there's going to be, actually, this is our one QR code. This is for everything. So this allows you to answer questions, allows you to ask questions, follow us along, and it does put you in the running for that gift card. So I'll give you a second to snap this. But yeah, definitely try to, and we've already proven the concept that we had a winner with our first gift card, so. She's going to take everybody out to Disney parks after this, and for, what is it? Is it $50? Yeah, $50. That buys you 2 churros. Good luck. All right, so congratulations. Enjoy your incredibly expensive churros. I brought a group of kids, my sons and their friends here last year. They wanted churros for breakfast. I'm like, sure, let's go. And then they ate like a quarter of them, and I was walking around with like 6 churros. Like, you guys have to eat these, because this was 1 week's salary for me. So I carried them around for quite some time. In addition, this allows you to view some the slides, practice aids, which we'll kind of highlight as we go through this session, and other resources. So this isn't it. If you go, for example, to the pace.alds or /alds.com site, you can get more information. To make sure that we get. That you can get more as we go through. So all of that is linked and should be on your devices. So I'm going to start with a brief introduction. Why early detection matters. How many of you are routinely identifying cognitive impairment as part of your practice? Yeah, great. Oh my gosh, that's awesome. Good job, everybody. Because we need to be doing better. Really, we are the sentinels in primary care, and so I really look to myself, and working in FQHC, I see patients with obesity, hypertension, hyperlipidemia, diabetes, and I've been there for a long time, so I feel like what I say is I've shepherded folks through the cardiovascular valley of death between ages 50 and 75, and that's great. They've seen, a great-grandchild being born, they went to a few quinceañeras, etc., but now they're 75, and guess what? They're getting forgetful and having some trouble with some of those cognitive function. And so it's those same, one thing we're going to come back to multiple times is those same cardiovascular risk factors we manage every day in the 40s and 50s come back because they serve as risk factors for Alzheimer's disease later on. Yet many Americans, of course, most want to know. And we'll go as to why. If you're asking, Why do patients want to know early? I think since so many of you are screening, you probably already know this, so I'd like to crowdsource that a bit, but I definitely have my reasons. And PCPs really are the ones. Why are we sentinels? I think we have two big advantages over specialists in this area. Not that, and it's collaborative. I would love teams, and I defer to specialists. They see this all the time, so they are the experts in terms of diagnosis. But one, we have pre-morbid knowledge of the patients, right? So we know that patient with those 4 chronic illnesses that always gets their labs on time, comes in for their vaccines on time, gets their cancer screenings and asks about them proactively. Now they're missing appointments, not taking medications, missing their labs. That's a sign right there. I'm going to screen, especially if they're 60 plus, I'm going to screen that individual for cognitive impairment. The other thing is many times we know the family, so we have nice reporters all ready for us who can talk about the function, how that patient is doing outside of the clinic. And I think those are two big advantages we want to play on in primary care, particularly in under-resourced populations. Those are big advantages in helping me identify patients with suspected cognitive impairment. And there have been these breakthroughs in terms of both in terms of technology, but also in terms of just the concept of brain health. And Malaz, I would like you to take this section if you can.
Yeah, and this is really the most exciting discovery and finding in the past maybe decade in particular. So I'm going to tell you about that from my perspective. I'm at very high risk for developing Alzheimer's disease and other-related dementia. Both my father I lost for dementia, and my mom just recently diagnosed with dementia. So I have technically 7 times the odds of developing dementia. The good thing is now I can reduce that odds by half with modifying my lifestyle risk factor if I have an amazing primary care doctor like you who will work with me on modification of my risk factor. Then if I get unlucky and unfortunately develop mild cognitive impairment or mild dementia syndrome from Alzheimer's disease, and I want to slow down that disease, the last 2 years we got now 2 FDA-approved medication for reducing amyloid-lowering therapy and reducing my functional and cognitive decline by almost a third. And then if I got really, really unlucky and I don't have Alzheimer's disease pathology, but I have mild dementia, but I don't want to leave my community, I don't want to go to the nursing home, and now CMS literally of 2025, now there's 400 facility an organization across the United States who are able to work with me, with my family, to keep me at home as long as possible without burning out my caregiver partner. So these are the 3 breakthroughs, will not be really operationalized if we don't have an amazing primary care system that start with the early detection. Back to you, Chuck.
Yeah, just because some of these, well, we still think, I think lifestyle, for example, is going to be something you want to use even after the diagnosis of Alzheimer's disease. Unfortunately, I identify most of my patients, they're already at Alzheimer's disease, not mild cognitive impairment. But, the lifestyle changes still can work. Even if you can't get an anti-amyloid therapy on board, there's a lot of things that you can do. And we'll get to that as we come through the session. Go ahead.
Yeah.
And, I'll just talk about our goals. So we are going to be talking about brain health, just the pathology and how we see this long course of pathology before there are any clinical symptoms. We'll talk about these modifiable risk factors that we can adjust. Then we'll be talking about how to identify it. And I do so from an expediency standpoint. I've got 20-minute visits. You might have 15-minute visits. How do you do this in a busy primary care practice? And then we'll be talking about, then once we make the diagnosis, where do we go from there?
Excellent, excellent. So building on that, there's some really key points here. When you look at AD pathology and understand how it fits into this time course perspective, this is really critical stuff here from a family medicine perspective. The idea that these amyloid and tau proteins are aggregating well before we actually see symptoms of cognitive impairment, right? So you have this cascade where you get these misfolded proteins accumulating around neurons, in neurons, and then that ultimately leads to cell death, right? And that's sort of the enemy we're trying to stave off, is we're trying to keep our brain cells healthy and robust and keep healthy connections between the brain cells. And then, so this is 20 plus years before those cells are dying off, we have this abnormal pathology. And then, years later, down the line, we've lost a significant amount of brain cells, we start developing cognitive symptoms. And this is where we can detect those cognitive symptoms in the clinical setting. And then as those cognitive symptoms progress, you develop functional deficits, and then by definition, you've crossed over into dementia And then this is if it's Alzheimer's disease, for example, we're talking about a slowly progressive illness for which there is no cure, right? A progressive illness. So what do? We have to get way ahead of this. We have to get ahead of this. So if you think about it, the time for true prevention is well before people develop cognitive symptoms. Those are the two main points here. Is one, it's a changing world in terms of the technology that we have to be able to detect these biopathologic changes and better characterize diseases like Alzheimer's disease. But then most importantly, the life course perspective. With all of our patients, we should be thinking about brain health at every age. Like everything else, it's a womb to tomb, cradle to grave thing. And these years, these decades before people have cognitive symptoms is when it's really time to be thinking about prevention. So, as I mentioned, it's a whole new world. So when you think about Alzheimer's disease, you have these biopathologic changes in the brain, and it used to be, that those same changes that Dr. Alwa's Alzheimer, that the eponymous Alzheimer's disease, we couldn't see those until autopsy, right? So maybe if somebody donated their brain, we'd know. But now we can actually see these things in vivo through these emerging blood-based biomarkers, imaging biomarkers, et cetera. And it's important to understand, though, that as we're thinking about this evolution of amyloid changes, tau changes, and neurodegeneration, that there's a known time course through which these changes occur. And once again, look at this. Those MCI changes come much later. So good news, we're able to pick these things up much earlier now with emerging technology. But remember that by the time people have MCI, it's late in the game. The other point to make here is look at that delta between low reserve and high reserve. And that is, I think that this picture doesn't do that justice. And I'm sure Dr. Vega can share about his experience with his patients where you see the difference where somebody has really built up a good, resilient cognitive reserve where they're doing all of that work to keep their brain robust, healthy. Regardless of underlying biopathology, that's going to make the difference. Regardless of underlying genetics, that's going to make the difference. So when we talk about this new ability to detect these biomarker changes, right? So now there's a new way of defining Alzheimer's disease. So we've been talking about cognitive impairment. We're going to talk about cognitive impairment and the difference between that and dementia based on a functional history. But in 2024, the Alzheimer's Association published updated biomarker-based diagnostic and staging guidelines for AD. Because now we have these core 1 biomarkers that we can use to detect AD in vivo. And so again, it's about characterizing amyloid pathology, tau pathology, and you can do that with CSF analysis, plasma, blood-based biomarkers, or imaging, for example, with amyloid PET scans. And as we know, thankfully, much of this is now covered by Medicare and more clinically widely available. That said, as we'll talk about today, this is an evolving story, particularly around the blood-based biomarkers. The CSF and the imaging we've had for a long time, well understood, but the blood-based biomarker, it's a little more convoluted story there.
How many of you have been referring your patients for imaging studies or CSF studies over time, or do you really make it more of a clinical diagnosis when you strongly suspect Alzheimer's disease? How many have used PET imaging? All right, has it been easily covered? Because there's only 3 of you, so that kind of gives me an answer. But yeah, I've had a lot of trouble getting, even though it's covered by Medicare, getting it actually through our system has been incredibly tough. So yeah, if you've run into these same struggles and you want to order these things, we'll talk about these different testing, this objective testing towards the end of the talk. So please.
Yeah, and that's where we'll talk about another role for specialty referral too, is even just navigating this complex system.
Absolutely.
And so picking up on what Dr. Boustani was saying, and I want to bring Dr. Boustani back in a second. So if you think about this AD continuum, there are unique opportunities at every stage for critical interventions, right? So again, emphasizing the importance of that early risk reduction. And then early detection and diagnosis so that when somebody has MCI, we can just get on it, bring out the SWAT team to make sure that we're addressing every modifiable risk factor, getting people connected to care that is available, getting people connected to the newly approved FDA approved treatments that Dr. Boustani mentioned. And then as people's disease progresses, we can't just say, oh, well, throw up our hands and think there's nothing we can do. That old thinking of why even bother, there's nothing we could do, nothing could be further from the truth. I mean, that's the point here, is that there's so much we can, should, must do at every stage of this disease. So even in the most advanced stages, Dr. Boustani was starting to talk about things like the GUIDE program, where we can actually connect people with interdisciplinary, supportive, 24/7 care that is going to make a critical difference in people's lives. Dr. Boustani, do you want to come back and shed any additional light on this topic here?
Yeah, I think that skepticism that happened about brain health maybe 30, 40 years when I started my residency, right now there is no data to support that such negative view. As I mentioned right now, risk reduction, it's a big factors that is under control primary care system that can prevent 45% of future risk of cognitive decline in dementia, including those caused by Alzheimer's disease pathology. And one of them that is under your control, you'll see, is deprescribing bad medicine, and we'll discuss that more. Then the early detections and the diagnoses to prevent harms, specifically for the early detection. A lot of people with Alzheimer's disease have other comorbid conditions, and they take a lot of other medications. So if your patient have heart failure and they are in and out to the hospital because their heart failures keep having exaggerations, then there is a chance that they might not be taking the first medicine you give them because they have undetected cognitive impairments. And then finally, if they have dementia syndrome, and they will be using the hospital and the emergency room in a very inappropriate way, and their quality of life will be significantly low, and their care partner. And now with the GUIDE model or the comprehensive dementia care model, you can optimize the quality of life for both of them. So now it's time for us to reimagine primary care as the place, the same way how we reimagined cancer care in the 80s and the 90s, and how we reimagined cardiovascular care in the 70s and the 80s. So this is now the new 21st century for reimagining primary care role in brain health in particular, and Alzheimer's.
Such great points. And so with that, we know this is not just the brain health is not just a squishy, nice idea. It's evidence-based. And so with that, take us into some of the evidence around, but first we have a question
So this
here.
one, you want to snap this if you haven't done so already, if it's not popping up. And this is just a polling question. We're not going to cover it, but I will, as you work through that, because a couple questions came in. When do you start discussing brain health with your patients? And what about controlling hypertension and diabetes? Does that really make a difference in Alzheimer's disease? We didn't go over epidemiology as much, but I just want to point out one interesting thing about the epidemiology of Alzheimer's that answers both of these questions. While we know the prevalence of Alzheimer's disease keeps increasing because the population is getting older, and that's really the single biggest risk factor when it comes to Alzheimer's disease, the incidence per million population is actually declining in the United States. Why? Two reasons. One, better educational attainment. So that's not something we don't have a lot of control over, but we really want, of course, we emphasize that to kids and young people, and we really want to keep people's brains stimulated throughout their life. And so so how early can you address it? Really in in infancy. The other factor is that's driving down the incidence of Alzheimer's disease is better control of those cardiovascular risk factors. You control lipids, A1C, you control blood pressure, you're making an impact on brain health positively over time. So that hopefully helps those two questions, but also gives us a little inspiration that we are doing the work, and a lot of it is on us as primary care, and it's coming out. So let's talk about management. So this is really, I think, a framework to think about brain health. And, there's things that we can modify, there's things that we can't modify. And yet, we really, of course, want to focus on the modifiable ones. Being African American, being a woman puts you at higher risk for Alzheimer's disease. And we always have to think about, and we'll cover in a minute, it's the socio-demographic risk factors, those social factors that affect health so much. Some of those are weaved into those issues as well. But this is a study that just came out. It was published only 5 months ago. And it looked at the work that we do every day in terms of advising about healthy diet, healthy sleep, nutrition, cognitive and social activities. Now, we know that we should be doing this, but it really provided, instead of the usual care group where patients were just recommended, as honestly, that's my practice, that's what I have available to me, where I tried to encourage it and follow up. This is where they actually got some extra support, and patients were really considered to be beholden. They were checked up on, did you achieve your goals? And we'll talk about how to set some of these brain health goals with patients shortly. But they did see a difference. They saw a difference, even start to separate within half year in terms of cognitive function. So it does show that the attention that we can provide to our patients, and that's where I think a lot of times we think, okay, this is going to be all on my shoulders. Now I have to set SMART goals and make sure that I check patients and are they achieving these goals. Think if you have any kind of resources, and that might be through Alzheimer's Association, or it might be through a senior center down the street, or maybe something within your healthcare practice, think about trying to outsource some of that, because if you don't answer questions about the knee pain and the blood pressure medication, which is causing brain fog or whatever, you're not going to be able to address some of these larger issues with brain health. So we have to really respond to patients first, because many times they're not going to be thinking front of mind about this because they're thinking about a risk that's far away. Okay, so these are your risk factors. I'm not going to read them. I'm just going to highlight a few. I'm going to start with just hearing impairment, and now vision impairment's been added. Those are the things that really stood out to me. I'm always emphasizing, go for the low-hanging fruit when it comes to cognitive impairment. If you can't hear well, if you can't see well, you're not interacting, you're getting more frustrated, maybe you're getting depressed, and guess what? That leads to more cognitive impairment. So therefore, those are the things. Hearing aid, if patients wear them. Vision aids, they're more likely to wear. That can make a big difference. The other thing I wanted to call out here is depression. So you have to treat the depression before, really, or at least concomitantly, along with the cognitive impairment, because they too are pretty hard to figure out in primary care which is one, which is the other. Go ahead and start working up and treating them both is my advice. And then social isolation is a huge one, especially since the pandemic, where we really saw it devastate these communities of older adults. And this is a real special interest for you, Scott. So I'll give you the floor to talk about that.
Yeah, I spent a lot of time thinking about social isolation and developing interventions in that space, and it's just unbelievable. I mean, we all know, right, that loneliness is as bad for your health as smoking nearly a pack of cigarettes a day, 15 cigarettes a day. Chronic loneliness and isolation increase your risk of developing dementia. We also know that people who are lonely and isolated have less self-efficacy, are less engaged. So all those things that we're trying to get them to do on these other things, the things that the Pointer study shows us work, that these things can reduce your risk of developing cognitive impairment, it's harder to get people over that hump to actually do those things that we're recommending if they're lonely and isolated. And finally, we know that when people are chronically isolated and lonely, they're more likely to suffer from chronic pain, insomnia, fatigue, depression. There are clusters that we know make for very challenging situations. So, huge issue. And just one last point, because this is huge. Look at this. So could you imagine if we addressed all of these things? If we addressed all of these things, we can't say to every one of you in the room, if you do all these things, you won't develop dementia. But if we thought across a population level, if we got everybody engaged in all of these addressing these risk factors, we could nearly cut the future dementia prevalence in half. I mean, that's striking. Go from 150 million projected worldwide, cut that number in half. So this is a really important opportunity for all of us in our clinical practice, and I think in our broader advocacy to think about opportunities to address this huge challenge.
And I guess I should have, that's great. I totally agree. Social isolation, if you reverse it, even in a low income, disadvantaged population, experiencing poor levels or in social injustice, social isolation can improve all of their health outcomes remarkably if you improve that social isolation. I will also say, I'm sorry, but everybody here today, I should have put this disclaimer at the front. At some point during today's talk, one of the side effects of going to a talk about dementia is you will think you yourself have dementia. So it's okay, you don't have dementia, but if you're agreeing with 95% of what we're saying, then yeah, talk to us after you might have dementia. No, you don't.
And that's an expanding list too, by the way. If people saw things that they think, oh, why aren't that on the list? That's just the evidence-based guidelines that continue to evolve as this commission meets.
So I don't use that many screeners. We're going to talk about screenings for cognitive impairment. Everybody gets a depression and anxiety screen in my practice, especially when they have cognitive impairment. I don't honestly do screeners for social isolation or for frailty, but those are good things to think about. But I definitely think about those issues on the top. And when it comes to, you're not going to be able to control all these. And we have a few patients who are unicorns who really change their lifestyle and everything turns around in 12 months, and that's outstanding. But 98% of people are incrementals. So go for where they are. If they're willing to change their diet, work on that. If they're willing to take another medication for their blood pressure or for their diabetes, go for that. But you have a lot to work with here. Don't forget about sleep, don't forget about mood, don't forget about chronic pain for that matter. Because all of these things go into it. So start with the thing that the patient is most interested, practice patient-centered care, get them to win with that early success, they're going to be more encouraged to continue that success. And as Scott said, follow your instructions later on for taking your medications and following other lifestyle issues. And then they're going to come up with their own. One of the lowest hanging fruit is just take away the medications that could be dangerous. So anticholinergics, obviously, the pathology of Alzheimer's depends on acetylcholine, so giving anticholinergics really doesn't make a lot of sense for those individuals. Sometimes you absolutely need them, but just look through that list and make sure that, I'm just going to highlight here, these are not all anticholinergics, but some of them are, like up here. But then muscle relaxants, I have no idea how baclofen became so widely prescribed for like, hey, I lifted a box, now my back hurts. Well, here's 60 baclofen. We used to use it for cerebral palsy and severe multiple sclerosis, but now it's for you 84-year-old. No, stay away from hypnotics and opioids too. Yeah, so these are basics when we're taking care of older adults. So I mentioned it's important to have these conversations because we can do something about it. We can do something about it at every stage. There's life planning involved. You have that big trip you want to take. You want to maybe reconcile with the brother you stopped talking to 30 years ago. Once you get the diagnosis of Alzheimer's disease, patients always come to me. I don't know, it's one of my favorite questions with older adults, which is most of my practice. And it's like, can I take this trip? Can I go to this, go to a national park? Can I, is it okay to have, can I take emotional distress if I talk to my brother at this point? The answer is 99% yes, 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 especially with Alzheimer's disease, because it's not going to get better. So, really now's the time to act, and we want to know that. Yet patients, in my practice, the main issue is knowledge. When I say, ¿sabe qué es la enfermedad de Alzheimer's? About 70% don't know what I'm talking about. And much less mild cognitive impairment, which most U.S. adults think is part of normal aging. And we'll get into the difference a little bit as we go through. So it's a lack of knowledge, and then there's shame and stigma. And I understand the fear associated with Alzheimer's disease because it is feared more than cancer. I have a lot of cancer survivors in my practice. I have 0 Alzheimer's survivors in my practice. But one of the principal fears among individuals experiencing cognitive impairment when it comes to Alzheimer's is being a burden on their families and their loved ones. And so you want to start addressing those things, oftentimes with supporters, and that's a beautiful thing about my practice. I've got access to supporters. If I ask, hey, is it okay if I call your adult kid? I always get a yes. So those are things. And it starts with just limited goals. Go where the patient leads you and move forward. The practice aid has more specific advice about this, so I'll just call out that you should refer to that. And then we're going to get to a couple cases now to start cinching some of these concepts up. We're going to introduce Claire. She's 47. She has memory concerns over the past 6 months. She's a partner at a corporate law firm. She's married with 2 teenage children. Let's go over here to visit notes is the best. So what exactly is she feeling? She's reporting some word finding difficulties, and she's forgetting what to buy at the store. It's unusual for her, so I get it. We should address this, absolutely. She has work stress, disrupted sleep, frequent all-nighters. She's concerned about her risk of AD and her mother's recent diagnosis. Oh, her mom. So family history is a risk factor for Alzheimer's disease, and she doesn't want to end up like her mom. So looking at her other history here, LDL is higher than I'd like it, her blood pressure is higher than I'd like it, and again, we have antecedent results so we can look back on, so we know we're kind of losing it there. I'd be interested to know what her previous BMI was too. Drinks 1 to 2 glasses a night, follows a vegan diet. You get a little concerned about B12 deficiency. Atorvastatin, I'll just get it out because it's going to be a question. Statins don't promote Alzheimer's disease. So that's not on my list of things to address. And then getting a good history with her mother too. So we're not going to dwell on this, but I'm just introducing now. We're going to come back. Instead, what I want your information on is a totally different case. It's Terrence, a 56-year-old gentleman, and he has an annual exam and he's here for refills. Traveling sales manager, recently divorced, over to visit notes again. So he's fatigued, doesn't sleep well, uses a sleep aid, diphenhydramine, wakes up with a headache almost daily. He's been using it for 15 years. He's got some anticoagulatory side effects. I think we can see where we're going here. He's got a little bit more serious situation going on in that he's got pre-diabetes. His blood pressure is better than it was, but he is taking some medication. So let's take a look at the list. Do we have risk factors? Well, how many of you see a risk factor there for cognitive impairment in this list? And which one, if it is, call it out. Which one's a problem? Diphenhydramine. Okay. Anyone others? The lisinopril could be doing it? All right. And the sertraline, sertraline can be a little sedating. I generally think it's safe, especially used over time, but the diphenhydramine stands out because for many of these patients, they're not using 25 milligrams a night. They're using 150 milligrams a night because with all antihistamines, you end up getting what? Tachyphylaxis, right? So especially in their histamine function, but even for their side effects, you get some tachyphylaxis. So people are taking these crazy doses. Also, he's drinking a few beers a night. He's traveling a lot, and we don't know about his family history. So what stands out to you? So we identified the diphenhydramine. And so what stands out to you as well with regards to, actually there's a question, so I'm going to ask it, then we're going to come back to the case. So your patient, he's heard that this insomnia is associated with risk for dementia and has difficulty sleeping most nights. He's taking his sleep medications. How would you counsel him? Would you tell him that insomnia is a risk factor for dementia and recommend that he take diphenhydramine before bedtime? Tell him that he is too young to worry about dementia, but that he should consider weaning off the OTC sleep aids due to their association with increased risk of AD over time? Recommend steps to improve his sleep hygiene and suggest that he discontinue the OTC sleep aids due to their association with increased risk of AD over time. Advise him to continue taking OTC sleep aids as they're needed and reassure him not to worry about the risk of dementia. Or 5, I'm not sure. I know that one of these answers seems really wrong. Let's see if somebody wants to make my head explode by picking that answer.
Channeling good energy.
Yeah, there you go. I don't know. I don't know if that's good energy. That's angsty, my energy.
Okay.
No one marked it. All right, number 4 was kind of bad. Steps to improve his sleep hygiene. This isn't going to be a story that you're going to get done in one visit. He's not going to stop the med today, and nor would I advise him to, and have perfect sleep. But I think that that's probably the one thing that we work on over time. If he says, absolutely, I'm not doing that, I need that, I tried to go off it, yada, yada, okay, let's work on something else. What are some of the other things, maybe just shout them out that you could work on with him? Could we go back? I'm just going to, before we go,
And I think people were shouting out
yeah,
about
go for the case. Alcohol? Smoking, yeah, great. Yeah. Blood pressure too, yeah, I agree. And his lipids probably could be a little better, but then it's I would say that, and the amazing thing is when you say like, I want that diphenhydramine off, and he gives you the hard stop, it's not happening. Okay, well, is it okay if we talk about some of the other habits you have? Guess what? He's going to be much more amenable to talking about those because you respected him and slid something his way. Now he's going to slide something your way, and that's what I find. There's negotiation all the time in primary care. We always have something else we can do. If you're blocked, that's too important for you. You don't want to make that change. Okay. And by the way, maybe we should talk about smoking.
Might want to make sure he doesn't have sleep apnea.
Yeah, that's a good point, too.
That's a really good point. That could be a major, and we could make a big difference.
Yeah. Okay, so let's talk about how we can actually do this stuff. Whom do you screen? Anybody with an adult who has cognitive complaints, I screen. Those folks who don't have cognitive complaints, but I see they're stepping off in terms of their ability to follow up. Having a chronic disease is like having a complex mental task. I see them falling behind in that. I screen them. And then the American Academy of Neurology, Medicare wants you to screen every adult over 60 or 65. So, and that could be a really simple screen like the mini-cog, or just asking if you have any problems with memory, if you're really pressed for time in your practice. But there are some formal screeners we'll talk about. When I'm thinking about potential causative and contributing factors, we covered a few of them. I'm a lab minimalist. These are the labs I would order. You don't have to go crazy. If you have a patient who hasn't had an HIV check, who is at risk for syphilis, who is at risk for other nutrient or has a history of other serious electrolyte abnormalities, maybe an inborn error of metabolism, definitely get those checked as well. For most patients, this is all you need. It's not very fancy. It's also not usually that informative because I've diagnosed over 100, 200 people. with dementia, and I've never had somebody like, oh, your thyroid is really, really low. That's never happened once, but everybody thinks it's their thyroid. But it's worth checking. Go through the medication list and alcohol and recreational drugs. These are the low-hanging fruit that can make a difference right away. And then you really want to start thinking about, okay, what kind of cognitive impairment do they have? And we'll get to that in a second. But I'm going to go through a toolbox. So how many of you use instruments to identify folks, like these instruments that you probably recognize if you're using a Minicog, MSE, SLUMS? Okay. I would say that we now have guidelines just this year that recommend the MoCA and the SLUMS as probably the best because they are very excellent at identifying mild cognitive impairment. They're fairly easy to do in your practice. I do both the MoCA and the SLUMS. I find them pretty similar in terms of my patients being able to do them. But because a lot of my patients have an elementary school grade attainment, just taking a test is really a struggle, so I like to do the tests myself just because I do grade them on a bit of a curve when I watch them taking the tests. So that's important to know. The Minicog, I do use it. I do use it as kind of a reassurance, usually for folks who have a very low premorbid or pretest risk of cognitive impairment or Alzheimer's disease. Kind of think of our Claire situation, and that's going to make her feel better, but then we can focus on other things that might be affecting health. And I would just mention the RUDIS and the 88. RUDIS is something that's relatively new, but it has been validated specifically in low educational attainment populations, which is if you're working in FQHC like mine, that's important. And the 88, that's a reporter. So that's not the patient, that's a reporter. It's very easy, and I find that when you get a positive MoCA compared with, and you also have a positive 88, you've got a very strong impetus for diagnosing Alzheimer's disease. Yet, that is not the be and all end all. Any comments on your favorites here? Or?
Yeah, no, I mean, I think you nailed it. I think the Minicog is really great to have that implemented widely into your practice, right? Part of the annual wellness visit. But you need to understand the limitation that it's just not as sensitive for mild cognitive impairment. So if you want to sort of go a little further upstream, you're going to have to use one of these other tools, and then that's where it's just what you're familiar with. The Montreal Cognitive Assessment, I'm just a huge fan because there's online training, it's free, it's available in multiple languages, and I just really appreciate the way it's broken out by the different domains. I, too, indulge in doing it directly with the patients myself, so that I can really see the whole experience. But you can train somebody on your team to do it in your place. So, but then the SLUMS, I mean, a lot of it's just kind of what you're familiar with and where you trained. Whatever tool you use, just use a validated one and take advantage of the training so that you really know how to use it.
Yeah, this is something is better than nothing. I would just add, Mental has been very popular for years. Most of us aren't using it and paying for each time we use it. But also, it's just not as effective it's very focused on memory, less on executive function, which is another major. So you really want to try to get something that's a little bit broad in terms of domains, and SLUMS and MoCA can get that for you. So let's go back to Claire. So let's just shout out your answers. What are some of the reversal factors that may be contributing to Claire's symptoms? Any ideas? Alcohol again? So, well, do you think that it's 1 to 2 drinks of wine per night? Do you think that in of itself, or are you more worried that 1 or 2 is turning into 5 or 7? Okay, gotcha. I'm with you. Any bit of alcohol is bad for brain health, but yeah, I think that, maybe get a little bit more history there too. You could do an audit, for example. That would be a good screener for her. That's one I do use in my practice. Any other things that could be factors? Sleep. Family history is huge, so yeah, great. And how many of you would use a MoCA? I'm just going to start with the most popular ones. How many would start with maybe a MoCA on her? How many of you prefer SLUMS? And be honest, this is not graded, obviously. Mm-hmm. How about an MMSE? Few of you? Okay, that's good. And how many Minicogs? So I might put her on the Minicog. This is my bias, so I might be missing MCI in 47-year-olds, but I don't think I am. So because there's so much to work on. And then again, the key here is follow-up. So maybe we advise her on some of those lifestyle changes. She passes her whatever test we use. How fast would you follow Claire up? 6 to 12 months? 6 to 12 months going once, going twice, 3 to 4 months. So, Oh yeah, and perimenopause too. Yeah, that's a really important factor. 47, she might be having irregular periods, so think about, does she have vasomotor symptoms or sleep and things like that? So absolutely. Does she have sexual symptoms? Absolutely, start thinking about that as well. Yep. Yeah, for sure. And I think the stress, it's hard to, but maybe she could do something in mindfulness. I think that has something, and that will help with her, probably with her sleep too. If she can look at her career and maybe try to ratchet some things down a little bit, she might just be too spread out. Okay. So yeah, and then when it comes to these factors, just be aware that certain factors can affect the testing. What I see a lot is, I think the two biggest factors are your educational attainment. How used to testing are you? And then two, the other one is mood. If you're really depressed or highly anxious, you're also more likely to score poorly on a test, but it's not a buildup of amyloid and tau in your brain. Okay. With that, I think we're going to turn it over to you, Scott.
Yeah, so I think, as we continue thinking about those cases, keeping the cases in mind, and as we think about the progression of the disease, just remember how important it is to also obtain collateral history, right? There's so many things that we see patients for that we can just get all the information directly from our patient. But dementia, cognitive impairment, a little bit unique in that we really need that additional outside perspective, right? We know that part of Alzheimer's disease may be anosognosia, right? That people just they lack insight into their symptoms. It may be that people are experiencing subtle changes that are going on over a very long period of time. And as we will get further into this, we see that to differentiate MCI from dementia, it's really about functional history and functional impairment. And so to get that functional history, you really need that outside perspective from somebody who knows the patient really well. And once again, there are plenty of validated tools that you can do this. But again, so the idea is that we're not just thinking about memory, right? We're not just thinking about forgetfulness. We're thinking about changes in cognition across multiple domains. We're thinking about changes in behavior, right? That these subtle behavioral changes are often missed. That's where I will see a lot of people where the signs were there well before they presented for care, because somebody who was usually, very easygoing is suddenly very uptight and concerned about everything, and vice versa. So, and then again, so important to be able to identify those functional changes, and we need that to be able to understand where somebody is in the disease course. So we have another case now. We've got Salvador, 70-year-old gentleman. He's a retired construction worker. Spanish is his first language, limited English proficiency. He comes in with his wife, who has noted that he's been increasingly forgetful over the past year. And sometimes he is forgetting to take his medication and accidentally doubling up on his doses. Now let's go over to our visit notes here. Let's see, I don't remember how to do the pointer, but that's fine.
Right
Thank
there.
you.
Yeah.
I love that. So no falls, but his gait's unsteady. He's concerned about hearing loss, but he missed his appointment for the hearing aid fitting.
Nah.
He also missed a recent colonoscopy appointment. And by the way, he thinks he's fine. He thinks this is all just normal age-related stuff, not a big deal. But his wife says, no, this is not normal. Again, remember that collateral history. This is not normal. It's happening way too much for it to be normal. I'm concerned. All right, so he's got hearing loss. Here are his medications. I don't know if anything's starting to stand out to you guys there. Hopefully, as a geriatrician, I'm channeling you guys to be focusing in on at least one of those medications there. And
They're laughing.
Okay, good. He has hyperlipidemia, hypertension, type 2 diabetes, so no shortage of modifiable risk factors here. No family history. Based on this, we're gonna dig a little deeper, and we'll come back to Salvador. So now again, let's talk about, we're going deeper into the diagnosis here, right? Because what we're going to do is we're going to characterize these cognitive changes. We're going to then characterize functional changes, and that's going to be able to help us understand whether somebody has normal age-related changes, mild cognitive impairment, or dementia. Then we'll start thinking about the underlying etiology. So it's just important to understand that there is this spectrum, right, where somebody might be totally cognitively unimpaired, that's wonderful. Somebody might have subjective changes, and maybe that is a first sign, or maybe it's normal age-related changes in cognition, right? We do have normal age-related changes in our cognition. And in fact, some areas of cognition actually improve with age. Nobody ever talks about that. But that's where we have to start distinguishing, is this something that they're just worried about, or do they really have objective findings that are beyond what would be expected for age? That's mild cognitive impairment. And at that point, it's not causing any functional loss of ADLs, IADLs, because once it crosses over into that by definition is when you have dementia. So mild cognitive impairment, again, we'll emphasize this, is a diagnosis in and of itself. And then there's the progression of the disease. It's very important, especially now, it's always been important to recognize these early stages for the reasons we've emphasized in terms of prevention and risk factor reduction. But now, more than ever, because we have approved drugs that are only available to people who have mild cognitive impairment or mild early dementia with underlying Alzheimer's disease, it's very important to be able to catch those people in those earlier stages if they are going to be potential candidates for these treatments. And now, as we proceed through our cognitive workup, right, we're getting that collateral history. We got those labs that Dr. Vega mentioned, and we've used our validated cognitive assessment, MoCA, SLUMS, whatever you're comfortable with, and we have to get neuroimaging. I can't tell you how many people come to me and they're just said, oh, here, take donepezil and call me in 5 years, or don't worry about it, it's just age-related, and no further workup was done. You have to get neuroimaging, and MRI is definitely the preferred modality here. It's non-contrast, no gadolinium needed. You just need a plain old MRI of the brain. You are going to get a very important view structurally of what's going on. You will see specific patterns of neurodegeneration, of volume loss, and you will also see those co-occurring vascular changes. And you're ruling out other pathology, right? Subdural hematoma, hydrocephalus, a brain tumor. And so, yes, you can achieve some of those high-level things with a CT, but you're going to get a much better view with an MRI, and you're also avoiding the radiation. So we've started to figure out, that there's a cognitive issue. We've dug further. We've evaluated it with a good validated tool. We've gotten a robust history, including functional history, not just from the patient, but also from the care partner. We've reviewed our labs. We've reviewed our MRI. And now we can start thinking about, okay, at this point we should have defined, do they have subjective cognitive impairment, mild cognitive impairment, dementia? If so, what stage of dementia? Now, why do they have that? So now we start thinking about, is it Alzheimer's disease? And then putting all that information together about how they did on the MoCA, which parts they struggled with, what we saw in the MRI. Or maybe there are co-occurring symptoms like gait issues, tremors, maybe there's nightmares, hallucinations, other things that might suggest another etiology. And again, this might be the point at which you're thinking about specialty care referral, but we should certainly be thinking about clues to a potential underlying diagnosis. And I would say with this, probably most pressingly, we want to start thinking about, is it Alzheimer's disease? Now, if you just are playing the house odds, most likely it's Alzheimer's disease, or Alzheimer's disease and a combination of something else. But we want to figure out if it's Alzheimer's disease so we can figure out if somebody might be a candidate for the treatment. So let's come back to Salvador. So he's been increasingly forgetful over the last year, right? And he's also, look at this little subtle behavioral change. He was always outgoing, extrovert, and he's just a little bit more withdrawn, even from the things that he most loves to do. And so we were doing this workup. We saw that he has hearing impairment. Remember our list of modifiable risk factors? That's a huge problem. Blood pressure, how are we looking there? We did at 88, so we got that perspective from his wife, and she definitely pointed out things that suggest cognitive impairment. We did a MOCA, and he's got multiple deficits across these different domains here with a score of 21 out of 30. 26 out of 30 is the cutoff, but then you depends on educational attainment level, could be 25. And then no functional impairment. Okay, so pictures coming together here. Somebody who has subjective and objective cognitive impairment, but no functional impairment associated with that. Yeah, he's got some depression symptoms, and we see that his other comorbid risk factors are certainly not optimized. On his MRI, we do see atrophy. You know, they'll just read it. Hopefully, you'll never get a scan where it says Alzheimer's disease. You can't diagnose Alzheimer's disease from looking at an MRI. But hopefully, you'll get something a little more than just general atrophy, you know, maybe a little bit of commentary. And here, when we looked at it ourselves, we actually saw that the hippocampi were clearly, that there was volume loss there. That's very concerning. So, I think we've kind of emphasized these points, right? But now how does this really present in the clinic? Well, age-related stuff, people may be forgetting things. I forgot what day it was. You know, retired people all the time, they're saying, I don't know what day it is. I'm retired. Why would I need to know that? But then they'll remember. Or, you know, we all do this. We go into the kitchen and say, what the heck did I go in here for? But then you will remember. Right? As opposed to kind of going into the kitchen and not remembering even what you do in the kitchen, right? As opposed to just forgetting why you went in there, but it'll come back to you. When you have MCI, clues may be something like asking the same questions over and over, even just 30 minutes apart. It happens all the time. Dad, just ask that. And then you are struggling to complete complex tasks, but by definition, you're still independent with ADLs. Whereas with dementia, that's where you're really struggling to function independently. And then the degree to which that is what defines the stage of the dementia. But that's just a very important thing, because MCI is not just early dementia. It is a diagnosis in and of itself. And like I said earlier, we want to catch MCI, and we want to catch it as early as possible. And when we find people with MCI, that's when we want to bring out the modifiable risk factor SWAT team to try and do everything we can to give this person the best chance of not developing dementia. Because not everybody with MCI will go on to develop dementia. They are certainly at greater than threefold risk of doing so, but not everybody will. So how can we fight with our patients, advocate, work with them to keep them in the camp of people who can actually preserve their cognitive and functional status? So, okay, we've got a question here for Salvador. We've gone over his history. So does he have mild cognitive impairment due to AD? Does he have mild dementia due to AD? Pseudo-dementia due to depression? Hyperglycemia? Normal age-related cognitive changes, or I'm not sure. Go ahead. Oh, I don't get the music this time? Thank you.
You got special music, but you do have to do an interpretive dance, is why I know.
Oh.
Go ahead.
I wasn't ready for that, but...
Well, you actually did it. Get a little punchy up here after a while. Must be the cognitive impairment.
Well, we're gonna definitely go over time here, so I'm trying to warm them up to that idea.
No, we're gonna go fast. Yeah.
Okay. Excellent. Okay. So I just want to belabor this point because it's so important, because some folks still think he has mild dementia due to AD. So I like that we're thinking due to AD. There were many clues that he most likely has underlying Alzheimer's disease. But can anybody yell out, why do we know it's MCI by definition? I wanted to belabor this point that he is not significantly functionally impaired. He is functionally independent. He still has MCI. Also, by the way, his MOCA score is more consistent. It's just a number, but it is more consistent. Everything in his history is more consistent with MCI. But by definition, that functional questionnaire, we did a validated objective tool. We'll take questions later and try and put the questions through the thing so we can see them and the people online can participate as well. Perfect. But for the majority are cluing into the fact that we're talking about, and I'm trouble advancing the slide here. Because we're going to bring in Malaz to comment
Any
as
quick
well.
points on that, Malaz?
I think the clarification of you need to be proactive in assessing the functional status of the patients after you can demonstrate there's a presence of cognitive deficits, because that's going to be very crucial to meet the criteria for dementia. Dementia requires you to have cognitive deficit that led to functional and social disability. And that's where you need a care partner, and maybe the functional assessment questionnaire is really, really good for you. So I think this is a clear mild cognitive impairment, due most likely to Alzheimer's disease, just because by playing the odds, but we can now confirm if it's due to Alzheimer's disease or not with these biomarkers based testing.
Excellent, excellent. And that's where we're going to go with Salvador here. So again, just to reemphasize, you can see it again. We know that he has MCI. We're thinking it's AD, as Dr. Boustani said, playing the odds. But also, if we looked back in more detail, his MoCA profile suggested, remember he had that hippocampal atrophy on the MRI. He didn't have a lot of vascular disease on the MRI. We know that there could be contributing issues with the hearing loss, and again, these comorbid vascular risk factors. So what are we going to do? Are we just going to barrel in and not even say good morning and just say, you have Alzheimer's disease? You have mild cognitive impairment? Absolutely not. This is a very sensitive issue. There's big implications for patients, for their families, for their work, if they're still working. I mean, this is not something that we're just going to do, and it's not something that we're going to do all in one visit. So what we're going to do first is we're going to open the door. We're going to ask permission to the patient and their loved ones. We're going to say, hey, is it okay if I share what I think's going on here? And then let's start, because this is going to be a shared journey we're going to go on together. And we need to start it in this way where we're not taking the lead. We're asking the patient, the family, if it's okay to proceed. And then we start talking about acknowledging the fear they may have, but also not being a Debbie Downer, not being so pessimistic like so many of us often are, to say, hey, look, we can bring a hopeful perspective here because there's so much we know we can do. Right? We're at the foot of a very long path that we will take together. And then we can indicate the ways we're going to provide support and let them know that this will be a long process that we'll take together. And there was a great resource I didn't know about that you can check out here through the AAFP that's got wonderful resources here to help you through this process, this cognitive care kit. So that was pretty cool. I wasn't aware of that. So if it looks like the patient has MCI or dementia, again, we're going to work with them to develop a plan. We want to make sure it's built around what matters most to them. Like Dr. Vega said, we might not be able to get them to address all of those modifiable risk factors, but maybe we will be able to use the leverage, the opportunity, the shared platform of the things that really matter with them, the playing with the grandkids, the hope of traveling again, to be able to do that. We need to understand their goals and preferences to make judicious, informed decisions about whether or not we're going to be pursuing biomarker testing to determine whether or not we're going to pursue anti-amyloid targeting therapy with these infusion monoclonal antibodies. So this is really key, and again, we need to be thinking about those modifiable risk factors at every point along the way. So now let's talk about biomarkers, and specifically blood-based biomarkers. So these are really going to be used as a helpful triage tool. So a positive result is going to identify likely amyloid pathology, and it's going to be something that there's going to need to be some subtle discussion around and probably further workup. A negative test, by the way, suggests that the amyloid pathology, so the biopathology of Alzheimer's disease, is unlikely. But again, we're going to have to couch this within sort of the probabilistic component that we're thinking about likelihood and risk. These really they're not screening tools, by the way, to be used on any asymptomatic patient to just say, hey, let's just get this test on everybody. It's really about thinking about these within the clinical context and understanding that there are limitations, false positives, false negatives. But this could be an important step for us in terms of better defining what's going on in this particular patient. And I would say that, again, maybe this is the point at which you think about specialty referral. The role of blood-based biomarkers in primary care is really an evolving story, and it's something to pay attention to and stay tuned. So we have another question here. So our 65-year-old patient with MCI has a positive blood biomarker test. How would we interpret this result? Does this indicate the presence of amyloid pathology and should prompt referral? Does this confirm Alzheimer's disease as a cause of the patient's symptoms? Does it mean the patient's eligible for amyloid targeting therapy, or I'm not sure? This is a tricky one. Dancing, by the way, is probably one of the best things you could do for your brain health and for depression.
So we're
I'm not depressed.
just housekeeping while he does that. I'm going to say that, which is outstanding, by the way, dancing with a star here. We are probably going to go a little bit long, so just bear with us. We're going to do a giveaway at the end, and we'll have a little rapid fire Q&A, and I'll hang out if there's any other questions. But yeah, go ahead and go over the answer.
And the majority of us got this, that this indicates the likely presence of amyloid pathology, and we should dig further, right? And maybe the next step might be an amyloid PET scan, for example. And this is where we could start having the conversation about amyloid targeting therapy. But it does not confirm Alzheimer's disease, it doesn't automatically mean that they're eligible for amyloid targeting therapy. There are a lot of other factors that go into it. One, we probably at this point would still want CSF or a PET scan, and we also need to figure out what stage of disease. So there's a lot of other things that go into it. Okay, let's keep going. So now, in terms of amyloid targeting therapy, right, this is a big topic. I'm sure a lot of you have questions, and if you have more questions after this, please put them into the question chat here. So these are the first disease-modifying therapies to be approved for Alzheimer's disease. And they're indicated for people who have MCI or mild dementia due to Alzheimer's disease. So they're monoclonal antibodies that are administered via infusion therapy, either once a month or twice every 2 weeks, depending on which therapy. And they are very effective in lowering the amyloid plaques, so much so that many people after 12 to 18 months will have no detectable amyloid plaques on an amyloid PET scan. And so very effective in lowering the amyloid plaques. A little bit more controversial is we know they actually overall have an impact on slowing of clinical decline. The controversy is on how much of an impact and how meaningful is it. Well, when you look at all comers in the studies, the evidence shows that we can slow clinical decline by 20 to 40% on average. Now that's on average. Some people, particularly if this is given earlier, are going to fare better potentially. And then if given inappropriately, not as likely to fare as well. So that's very important. That's another reason why we're trying to get upstream and catch these people early and really be clear on giving it to the right patient. But on average, this is equivalent to saving about 5 to 7 months of expected decline compared with placebo, right? So over 18 months, the idea that you might get an additional 5 to 7 months where you are more functionally intact, more cognitively intact, that you've not declined to the next stage, which can be a big difference for people. But for some people, this is why shared decision making is so important. When they think about the potential risks of the drugs, that's not appealing to them at all. Right? So this is where you really need to kind of put it out there for patients or refer to a specialist who can do this. In terms of the risk, the most common adverse effects of these drugs would be the infusion reactions, which tend to be mild and easily managed. The more concerning potential impacts would be ARIA, amyloid-related imaging abnormalities. And as the name suggests, they're just that for the most part of the time. They're just imaging abnormalities. So it sounds scary that you would see swelling or bleeding on MRIs, but for the most part, those are totally asymptomatic and easily managed by halting treatment, reevaluating, et cetera. But that said, very important to be aware of these so that if you have patients on these drugs that we're considering ARIA. If you're going to be treated with these drugs, there's a whole protocol for safety MRIs throughout the treatment course. But let's say you're staffing in urgent care, you're in an ER, and somebody comes in and they've got focal neurologic symptoms. Well, whoa, let's make sure that we know they're on one of these drugs because we don't want to mistakenly think that they're suffering a cerebrovascular event. We want to know that this could be ARIA. That's very important. So coming back to Salvador, so we explain all this to him because we asked permission and that's what he wants to do. And we realized that he could be eligible for amyloid targeting therapy. Why? Well, we're confirming underlying AD biopathology, and we know that he has MCI, right? So he's in the right stage. So now we're going to start talking about risks and benefits, just as I was now. And we're not going to forget the importance of addressing all of his other modifiable risk factors. That's key. On every patient, we got to be thinking about these other modifiable risk factors. We could make a huge difference for him immediately by getting him to the audiologist, but we also are making a huge difference in terms of modifying his long-term risk. And we're going to connect him with key resources, either online or in real life, that are out there. I spend a lot of my time building partnerships with community organizations, senior centers, Alzheimer's associations. They're worth their weight in gold. If you don't have those connections, you need to work on building those now. And so let's do another question for Salvador. Here they are. They're discussing the findings. And how are we going to start the conversation? Are we going to lead with the diagnosis so the patient and her husband don't have to wait in suspense any longer? Are we going to first acknowledge their fears? Are we going to first make it clear that this is the first in a series of visits and you will be there to provide ongoing support? Or are we going to first ask their permission to share with them what you believe is going on? Or are we still not sure?
Great, thank you. So while you're answering that, please do. We're about to wrap up. Let me just answer a few questions here really quick. ApoE, do we test it routinely? Generally, I don't. It's fraught. It can have effects in terms of life insurance and other planning. You can use a genetic counselor to have somebody talk to it if they're at risk for Alzheimer's disease. It does have a role, though. If you're going to send for anti-amyloid therapy, you should check ApoE beforehand because the more copies of that allele they have, the higher the risk of ARIA. So that is now we have a pretty strong indication there for that subset of people. Not everybody's going to undergo anti-amyloid therapy, but those that do. And let me just say, when do you send for biomarkers? I would do it when you do the MRI. Honestly, if screen positive, you got risk factors, you got clinical suspicion, MRI, regular lab, and blood biomarker. You could do it with your CMP, CBC, TSH, et cetera.
Great. Yeah.
Right.
And so nobody came in like a bull in a china shop. No, I like that. We're good. I thought this was a tricky question too, because of course I want to acknowledge their fears. Of course I want to make it clear that this is the first of a series of visits. But as you remember, those are all next steps. The first step is we ask their permission to share with them what we believe is going on, and that's how we start the conversation. Dr. Boustani, I know you've looked at this a lot. Anything to add on this?
Well, I think number one for me is to really split the journey into 2 visits usually. So because this is very important, I need to have enough time and space for them. So we usually do a family conference, and over there we always start, would you like for me to tell you the truth? Do you have any specific question about your brain health, about the results? And then we build on that kind of shared decision making to start telling them what's the cognitive problem. We usually use a visual aid, like we have a color, spectrum color of green brain, red brain, or yellow brain, and we tell them where they are, we tell them the etiology, and we start the working together, co-designing a brain care plan for them.
Great.
All right. All
All
right.
right, so specialty referral, I'll just say that I like to co-manage all patients with dementia with a specialist or MCI, any cognitive impairment, just because, again, it's more resources. It's not just for them, it's for their supporters as well. Together, you try to make a team. That said, definitely if there's a complicated diagnosis, you might have multiple diagnoses going on. You're having trouble getting a biomarker when you really want one. And when another question came in, I don't do infusions in my practice, so I have to refer on to a specialist, and they're going to be ones that initiate the steps to go to infusions. Take-home messages are here. I'm going to let you read them, but I just want to say thanks for being patient with us. Thanks for staying some extra time, and we are now at the end, so you can snap that. I think you already have it, but you should take the last survey, and please fill out your evaluations for credit. I'm happy to hang around for a few minutes if you have any more questions, but I answered the ones that came in. And I think with that, I'll leave this one up there, but we can go to possibly our last giveaway as well. I'll leave it up there for a second. There you go. So if you should have a blue bar on the bottom of your screen. Who won?
If you win this, you're 46% less likely to
I
develop
see you.
Alzheimer's.
Gotcha. Okay, so talk to
Okay.
somebody at Peerview.
Oh!
2 winners. 3 winners.
Oh!
Oh, it's a riot. Okay. No, thanks. Oh my gosh. There's a lot of winners. Okay, well, but the point is you're all winners.
Yes.
Thanks very much for attending. Thanks for your patience. I'll hang out for a minute. Have a great conference, y'all.